Shield Connect. I am Niranjan Chavan, Regional Medical Advisor from Shield Healthcare. It's my privilege to welcome you for this wonderful series, Trending Ask series, which is organized by AGOG, that is Academia of Global Obstetrics and Gynecology on Shield Connect platform. So in this task series, we will be covering the topics from A to Z topics. And today the episode E will cover the topic Enigmatic Endometrium. So before we start with the series, let me show the short introductory video of AGOG. With this wonderful video, now let me start the episode with small Vandana prayer.
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
Let's begin the episode E, and I am happy to introduce the Master of Ceremony, Dr. Pradnya Changede and Dr. Ekika Singh, ma'am. So let me introduce Dr. Pradnya, ma'am. Ma'am is Associate Professor of Department of Obstetric and Gynecology of LT, MMC and GH Hospital, Secretary and Manager of Journal of Obstetric and Gynecology of India, MUHS recognized PG and UG teacher, member of Youth Council of MOX, and published it several articles in index journals. And also let me introduce Dr. Ekika Singh, ma'am. Ma'am is Director and IVF Consultant at Sharda Narayan Hospital in UP. Ma'am has done Diploma in Reproductive Medicine from London and Germany. Ma'am is Secretary of Mao Obstetric Gynecology Society. Ma'am is member of Management Committee, ISAR, Executive Member of UP ISAR State Chapter, North Zone Coordinator of Foxy Youth Talent Promotion Committee 2020 to 2022, Champion of ISAR in 2020, Wonder Foxian Award by Foxy, Foxy Unsung Hero Award in 2018, Health Icon of Varanasi by Hindustan Print Medium, Best Paper Presentation Award by UPCOG 2018, Best Paper Presentation Award in UISAR 2019, Certificate of Excellence on International Women Days by Innerville. Ma'am has also published various publications and poster presentations and contributed to many research work. So I hand over this session to Dr. Pradnya, ma'am. We welcome you on our platform, ma'am. Thank you.
Yeah. Thank you, Mr. Nishan, for your kind introduction. I welcome you all to this Trending Ask series. And today we begin with the E, which is the Enigmatic Endometrium. And for this, I would like to welcome our convener for today's program, Dr. Komal Chavan, madam, and the co-convener, Dr. Niranjan Chavan, sir. Dr. Komal Chavan is a medical director, Chavan Maternity and Nursing Home. She is a senior consultant DNB teacher and unit chief at VN Desai Hospital, Mumbai. She is an ex-honorary professor, R.N. Cooper Hospital and HBT Medical College. Madam has been the chairperson of Foxy Medical Disorders in Pregnancy Committee and has done so much work during her tenure. She is a zonal coordinator of Foxy, chairperson AMOX Family Welfare and MTP Committee, managing council member MOTS. And I also would like to introduce our co-convener, Dr. Niranjan Chavan, sir. He is a professor and unit chief at Lokmanya Tilak Municipal Medical College, joint treasurer of Foxy. He is the current president of MOGS, member of Oncology Committee CEFOC, joint secretary AFG, dean AGOG, and chief content director at the FEMAS courses, editor-in-chief, FEMAS, JGOG, and TOA journal. He has had several publications. He is the National Coordinator for Foxy Medical Disorders in Pregnancy Committee, and Sir has several publications to his credit. I welcome the convener and the co-convener, and now I request Dr. Komal ma'am to invite our chief guest and our guest of honor for today's program.
Thank you so much, Pradnya. And at the outset, I welcome all of you for this Trending Ask series. And today, the E episode, that is Enigmatic Endometrium. And we know everything, it all starts with the endometrium. And we really want to have different problems. This episode is going to highlight various problems about endometrium and something which are really challenging and in our day-to-day practice. And that is the idea behind the webinar. And I take pleasure to invite our chief guest for today, Dr. Jaydeep Tank. May I have Sir's CV? I know Sir very closely. He is a president-elect Foxy. He was really a dynamic Secretary General of Foxy and has done such immense work for Foxy and made us all very proud. He's also the project lead of Foxy USAID project, which is an ongoing project. Has been also been the past president of the Mumbai Obstetrics and Gynec Society, immediate past deputy secretary, and now the committee chair of YGAA Committee AOFOG, and immediate past chair of Safe Motherhood Committee FIGO, awarded the FRCOG by the RCOG, consultant in Mumbai at Ashwini Maternity and Surgical Center for endoscopy and IVF, and has also been the program director and member of board of Profort IVF, and has been going almost a dozen of IVF centers all around the nation. Member of the National Coalition of Nutrition Board, IPAS Development Foundation, and independent director on the board of API Holdings, Pharmacy. So I think he's gone and ventured in everything what a gynecologist or a key person should be. And he has been leading us, guiding us in all the key issues in OBGYN. So I welcome Dr. Jaydeep Tank, sir, and I request him to address the audience.
Thank you very much, Komal, for that very warm, very kind, and very generous introduction. I hope I'm audible.
Yes.
It is my pleasure to be chief guest for this very important webinar. It's a part of the A to Z series in the Trending Ask series organized by the Academia of Global ONG with very dear friends as conveners and co-conveners. I remember when Komal was chair of the Foxy committee, I used to wonder when she gets time to do anything but work for Foxy. Sorry, Komal, you were saying something?
Sir, I think I'm not able to hear.
Okay.
Audio.
Ma'am, the audio is clear, ma'am.
Clear, sir. Audio is clear.
It's a connection, Komal, on your side.
We can hear.
Yeah, thank you. And I used to wonder when Komal used to get time to do anything else but Foxy work. The amount of work that she did as committee chair was really quite stupendous. And Komal, I want to wish you all the very best for all your future work in Foxy. And I'm looking forward to seeing you in the Foxy leadership and making a difference to women and Foxy everywhere. Of course, the co-convener is Niranjan, a very dear and close friend who's currently the joint treasurer of Foxy. And I had the good fortune of having Niranjan as my secretary when I was the president of the Mumbai Society. And gratitude also to the coordinators, Pradnya and Ekika, very hardworking and very dynamic individuals. It is, of course, my pleasure to have Dr. Archana Baser as the guest of honor. I had the good fortune of working with her for several years in Foxy. And I remember her enterprising spirit when she did the ultrasound training programs. And I do hope, Archana, that you find time to take that endeavor of yours forward. It was really a great enterprise and really quite beneficial to all those who attended it. Komal, I like the format of the program, 2 talks followed by a panel. It's a very nice, crisp format. And of course, you've got fantastic faculty. You have Shivani, Dr. Brijbala, Dr. Namrata, and Sumanji as the chairpersons, and speakers in yourself and Kundan. And then, of course, you have a wonderful panel with Ganpat as a moderator. Ganpat is an excellent moderator. always very practical and very engaging as a moderator, and expert is Niranjan, and such fantastic panelists, Vidya, Subhash. I know Subhash is not there, but I would like to congratulate him for that fantastic South Zone he had recently, which unfortunately I could not attend. And there's Dr. Dinesh Kansal, Smeet, Anu, Dr. Amit, Dr. Tanvir, and Dr. Anuradha. So thank you very much again, Komal and Niranjan, for having me here. It's always a pleasure and a privilege. And Komal, all the very best to you again.
Thank you so much, sir. That was really a great address to everybody, and we have been really honored for your esteemed presence. And now I call upon our guest of honor, Dr. Archana Baser. Dr. Archana Baser, we know she has been the past Vice President of FOXI 2020 and currently the Consultant Obstetrician and Gynecologist Director of the Akash Hospital, Indore. She also holds a Guinness World Record for removing the largest uterine fibroid and has been the Organizing Secretary of the AICOG 2020 to Indore. I think we really had a great AICOG, and we loved the hospitality and the warmth there. She has been the ICOG Governing Council member 2020 and 2022, the past chair of the Imaging Science Committee of CEFOC as well as AOFOC, and convener and founder of the FOXI Fetal Medicine Online Ultrasound Training, and organizing secretary of also ISAR 2016, fellow representative of AICC RCOG West Zone, and has been part of managing committee of IEG as well as ISAR. So welcome, madam. We are really waiting to hear from you.
Thank you, Komal, for having me here.
Madam, before, congratulations. You had a real milestone in your life, and I saw the lovely pictures, and really congratulations to you.
Congratulations, madam, from our side also.
Thank you so much. Thank you, everyone. And I'll pass on the congratulations to my daughter Anshu as well, because she needs blessings of all of you for her married life as well as her future in FOXI as well. So thank you, everyone. And thank you, Komal, for having me here. It was nice to hear from Jaydeep that, that this program of endometrium is being well crafted. And I know it is going to be well, and it will go on well because it is being convened and co-convened by the power couple of the FOXI, Komal Chavan and Niranjan Chavan. They are really hardworking and hardcore FOXians. So I'm sure it is going to be a good program. And I think it is neat that we have to learn the basics. Like endometrium is the basis of everything, whether it is a recurrent miscarriage or whether you're talking about infertility. So I'm sure you're going to hear from the speakers good take-home points from them about the endometrium. So all the very best for this program, Komal, and all the very best for your future endeavors in the FOXI, and may you continue with the same spirit, your work, and or you're an all-rounder, I know that. So very, very, very best, and thank you, everyone, and all the best for a good program.
Thank you so much, madam. I know you have been very busy for the last few days, but thank you so much for being here and joining all of us today. And I welcome all the faculties who have come here, our chairpersons, Dr. Suman Sinha, Dr. Shivani Gaur, Dr. Brijbala, and Dr. Namrata Bhardwaj. They all have joined. Pradnya, I'll hand over to you. If we just check, I think Dr. Kundan is getting delayed because of a photo shoot. Yes.
So, ma'am, we'll have the second talk first. I would like to request the chairpersons for the first session, Dr. Shivani Gaur and Dr. Brijbala Tiwari, to please introduce the speaker. Before that, I will introduce the chairpersons. Our first chairperson is Dr. Shivani Gaur. She is the founder and director of SCI Healthcare Hospital and Multi-Speciality Center. She is a consultant fertility specialist. She is involved with treating first cases of legal surrogacy in India. She has done IVF clinical research fellow at Hammersmith Hospital and practiced as a gynecologist and obstetrician at the Royal Infirmary of Edinburgh in UK. She is a member of the Royal College of Obstetricians and Gynecologists and leads the SCI Healthcare and SCI IVF Hospital Surrogacy and IVF programs. Welcome, Dr. Shivani. So the next chairperson is Dr. Brijbala Tiwari. She's a consultant gynecologist and infertility specialist. She's a credentialed menopause practitioner. She's a managing director of Life Care Hospital, Sanctity Infertility Test Tube Baby Center at LCH Nursing Academy. She's the current president of Indore Obstetrics and Gynecological Society, vice president IMA Indore branch, joint secretary MP ISAR, past secretary IOGS of the Indore branch, and organizing secretary of AMPOG. She's organized many live workshops and has been a faculty in national and international conferences. She's a recipient of the CS Down Best Paper Award in AICOG. I request the chairpersons to invite our first speaker, Dr. Komal Chavan.
Good evening, everyone. This is very privileged to introduce none other than good friend Dr. Komal Chavan, and she is a very dynamic secretary of MOX, and she is the medical director of Chavan Maternity Nursing Home. She is senior consultant, DNB teacher, unit chief of VN Desai Hospital, Mumbai, ex-honorary professor at Cooper Hospital, chairperson Foxy Medical Disorder Committee 2019-22, Zonal Coordinator Foxy, Chairperson AMOX Family Welfare MTP Committee, and she is everywhere present, so dynamic. She is present in every conference and with active participation. So she is very energetic, and we are eager to hear you, dear Komal. So please go ahead with your talk.
Thank you so much, Dr. Brijbala. Really happy to see you online also. We meet each other physically, but I think some short online programs are also that makes the continuity and the learning keep happening. So that is the idea. And I really happy that Shivani is there chairing the session along with Brijbala. So really happy.
Most welcome, Dr. Komal. Really, Dr. Brijbala was right. It is honor to introduce us for you to, for us to introduce you. And you are also a teacher for DNB. So we are really looking forward to your presentation today.
Yes. And Dr. Kundan being held up in a he is there in some organization, some photo shoot, and that is the reason he said, you can see my slide, I think.
No,
can't see the slide. It is just said that you have started screen sharing, but abhi slide nahi aaya. Now it is there.
We
can see.
You can see it, yeah. But
just go to slide share.
Yeah, I'm going to the slide share. I have to move my. It's come now. You can see.
No.
Yeah.
No, it's not come full screen, ma'am.
Yeah. I'm trying to make it full screen.
Ma'am, just press slideshow.
Yeah, that's true.
Just press slideshow.
I don't know. It usually comes very fast,
Upar wala, go to the top slideshow, see if that works.
Top only I'm trying, yeah. Top only I'm trying. Yeah.
But here it is showing your mouse is not moving.
Yeah, no, but here I can move my mouse. Okay, I will stop share and share again. Wait.
Yeah, share again.
Share again. So I think that will be better. I will do that again. So the topic now today, the idea, we all know, I think as an obstetrician, that how much importance we give to endometrium. And when there is something which is having an endometrial pathology, what usually happens is that we really, because everything starts with endometrium, right from the implantation to the pathology which goes on in the later life. So that all is a main focus. And the idea behind the talk is to know the simple techniques about endometrial hyperplasia, how to go about. Wait a minute. Now I think my presentation has just got closed, so I have to restart it. Just a minute, and then go to the slide share. What is the problem?
Ma'am, just open your presentation first.
Yeah, that's what I'm trying to do. I'm not able. It just got stopped. I'm opening it back. Yeah. Now I'll show. I'm just doing that. Because somehow when I closed the window, the presentation got closed. So I have to reopen it. You know, till the time the presentation is loading, I really want to make a vote appeal. So I think this is the right time not to waste any time. So all the viewers and everybody present here, after working as the chairperson for the Foxy Medical Disorders in Pregnancy Committee and moving around meeting, I really want to work more for Foxy. And I am contesting for the post of Vice President from the West Zone for the coming elections. And I please request all of you to please vote for me, support me, encourage me. Thank you so much.
2 votes.
Yes, for sure, ma'am.
Yes.
Definitely.
By the time Komal is opening her presentation, I can also request for my,
Yes.
I'm also contesting for Infertility Committee. I request your society to nominate and to vote for me.
Even I want to request. I'm standing for Chairperson of the Surgery Committee. So
all the best, Brijbala ma'am and Suman Sinha ma'am.
Yes,
we are with you. Fully backing you.
Yes, all those who are going for the elections, I think really we require everybody are really dynamic and doing such great work.
Yes, this is the app platform to request.
Okay, so can you see now?
Now it's visible.
It's visible.
Yeah. Yes, we can see. Just put on slide share.
Yeah, now I'll do the slide share. Yeah, I can do slide share from here also. Okay, so our slide share has started and now we'll go with the topic.
Yeah.
So let's start now. Okay, so now let's begin with this quote. If you change the way you look at things, the things you look at change. And really, we need to change our outlook sometimes when we see patients with coming with complaints. Yeah. So my topic today is endometrial hyperplasia. And we all know that hyperplasia means there is an excessive and hypersecretion of endometrium. And this is more common in the Western world. But now what has happened is that in the Indian people also are showing the incidence increasing almost 3 times. And we are really feared because of the progression to carcinoma. That is our main thing. And we know there is a hormone, estrogen, progesterone, everybody is knowing. But what is endometrial hyperplasia? Why are we worried? Because a report comes with a hyperplasia. We sometimes feel it is a pre-neoplastic. We know that the action of the estrogen is to excess without any optimum progesterone action. So we know that is a cause of hyperplasia. So evaluation is a key. And before we evaluate, we should know the risk factors. That is, if somebody has a longer duration of the menstrual thing, that is early menarche and a late menopause, or a nulliparity, obesity. Obesity is a really important key because of the aromatase in the adipose tissue converts androgen to estrogens, and these estrogens will keep on acting and on the endometrium, and it causes proliferation. So the obesity is more prevalent also in patients who are having PCOS, who are having anovulatory cycles, or estrogen secreting tumors, or hormone, or those one on hormonal therapy. So they've also become more prone to endometrial hyperplasia. Then we have the diabetes and the hypertension. Usually all this diabetes, hypertension, diabetes, and obesity, they become a triad, that is a corpus triad cancer syndrome. And so we really need to be checking out for these risk factors when we get patient, whether what is a BMI, whether there are any medical factors. And the classification, the WHO 2014 has said that a hyperplasia can be a simple hyperplasia without atypical cell. That is around chances of conversion to malignancy will depend upon which type are we dealing with. So this is really a normal variety where chances is only 1%. Then complex hyperplasia without atypical cell also will have though it is a complex, but the conversion to malignancy is really less. But simple hyperplasia with atypical cell, again, the conversion to malignancy increases. And if there is a complex hyperplasia with atypical cells, then almost 30%. And this is the most pathology which we are worried about, that the conversion to malignancy becomes very high, up to 30%. And this is how the endometrium will look. This is a normal proliferative. You see, everything looks normal. The shape, size, everything, glands look normal. Here, there is a variation in shape. So this is a hyperplasia where there is a variation in shape, and you can see a lot of cystic glands. But there is no atypia. Atypia comes when there are closely impacted glands, and you see the stroma also becomes relatively sparse. The nuclei and the nucleoli become a little indistinct. And this, the last picture, the D1, is an atypical hyperplasia. We see everything is so irregular, tightly packed, and we see the nucleoli a little bit larger, vesicular, and there is hardly any intervening stroma, and everything looks compactly packed. And this is how a complex atypical hyperplasia will look. So these two varieties, as by WHO, is that hyperplasia with atypia and without atypia is something which we need to distinguish in a patient of endometrial hyperplasia. Also, the endometrial intraepithelial neoplasm, that is EIN, they have also devised a classification, and this has been recommended by ACOG and Society of Gynecological Oncology. And here it is categorized as benign. So it is actually benign, is very simple, where we can give a medical treatment, and the treatment is based on which type are we dealing with. Then comes the pre-malignant. The pre-malignant is something that endometrial intraepithelial neoplasia, which has replaced the atypical hyperplasia. And here we need to counsel the patient, find out the fertility status of the patient, and then choose a method. So it requires a lot of counseling, and then you can choose a method. And then malignant is really a higher variety, that is endometrial adenocarcinoma. And here you require to do surgical staging and go to the higher modalities of treatment. So this is how the hyperplasia comes into picture. We know the progression is there, whether it is from hyperplasia. This happens usually in a premenopausal patient, wherein there is an atypical, non-typical hyperplasia with a lot of mutations, by acting a lot of mutation and others think it can become a complex atypical hyperplasia, and later on, slowly it can go into the low-grade endometrioid cancer. Also, in a post-menopausal woman, when there is an atrophic endometrium, the later on, because of the mutations, that TP53 mutation, it becomes endometrial glandular dysplasia, and here also it can lead to sarcomatous changes. So we really need to know, even in premenopausal and postmenopausal, this can happen. So what is the key now? Key is that we need to know what is the patient's symptoms. How will the patient present with? Just a minute, my slide is not moving.
Yes, it has stopped.
The slide is moving?
No, now it's not.
Okay, just a minute.
Ma'am, you need to stop share and share once again, ma'am.
Again, okay.
Yes,
I don't know what is the problem.
No,
Why am
Komal,
I
I think you have selected some part of the slide itself. The slide I was seen on the screen, the cursor has clicked on that. So click on the main slide. I think slide number 4 or 5, you were there.
Ma'am, just move the cursor out of that slide.
Yeah, now it's fine. Now it's fine.
Yes,
now
ma'am.
it's fine.
Great.
Yeah, thank you so
Now
much.
it's
Yeah.
coming.
No
So we really need to know the symptoms. So symptoms would be if the bleeding is more, that is for 7 days, and the amount is more than 80 ml. So this is the, usually we need to find out that AUB may be the common complaint, and also a postmenopausal bleeding. Diagnosis is very simple. We do a transvaginal ultrasound, and the cutoff, if it's premenopausal patient, so more than 7 mm endometrial thickness, along with the symptoms, or in a menopausal patient, if there is more than 4 mm, we perform an endometrial biopsy. It's a very simple technique, and I think everybody is doing an endometrial biopsy, and it is most recommended. There are various biopsy forceps and everything, so whichever is your convenient method, we can use it. But the indication, if the patient is symptomatic and more than 35, definitely just go ahead. But even in less than 35, if there is any other risk factors like PCOS or any tumors, you can definitely go ahead and evaluate the endometrium. Pippel's biopsy is something which is really inexpensive and most commonly does not require any dilatation. You really don't have to even hold the cervix spitinaculum. And the success rate also, the adequate sample also is very good. So Pippel's biopsy is common. These are the other, this is Explora. This is with the adjustable guard and the stillet and a syringe. This is by Cooper Surgical. This also gives a negative pressure. Then this is a Tau brush. It has a flexible brush. You can put it in the endometrium and collect the sample. So this is Tau brush. Then the Vibras aspirator. This is something which is more practical and has been used and quoted in many books. So this has a suction mechanism and a flexible straight cervical curettage. Then gradually move up and get, I think my slide share has stopped back. What is that? Okay, can you see now?
Yes, ma'am.
Yeah. Yeah. So, okay. And then the DNC, which we talked about, we can do it. But what is more important, what I want to highlight is hysteroscopy. And this is a gold standard. You can see it clearly visualized, and it can take a targeted biopsy under vision. So, and this is something which is really very important. And this is how the hysteroscopic view, you will see that you will see a hyperplastic endometrium, a lot of fluffy endometrium, and it can, and really you can see the abnormal place and take directly a biopsy at that place. So when we talk about the RCOG guidelines, the surveillance method, they also have described all what we have described, and also even highlighted that there is an insufficient evidence just to get a CT or an MRI or any biomarkers just for the diagnostic purpose. Now coming to the management, if the patient comes without atypia, the first line is an LNG IUS for 5 years, and second line is an oral continuous progesterone, and you give for 6 months. So after 6 months, if you feel that this patient is going to has still any symptoms or you want to evaluate, then you can check for if there is a bleeding. The bleeding has stopped, nothing to be done, but there is a recurrence of bleeding. You can take a Pippel sample, send it for histopathology and re-evaluate. And if it is showing the same, that there are no atypical cells, you can continue the treatment. But if there are atypical cells, then you have to manage as with atypia. Then duration, the LNG can be put even in postmenopausal as well as menopausal. So postmenopausal, after 5 years, you should remove it and screen the patient. But in perimenopausal, you have to reevaluate and check after 5 years whether you reconsider putting in another LNG IUS. What about the surgery for the patient who has no atypia? So surgery becomes actually a second line. We should not push in all the patient just for surgery because they have AUB and they have endometrial hyperplasia. Only patients who are really don't want to undergo any follow-up. If there is persistent bleeding, who have relapse of hyperplasia even after taking progesterone therapy, and even the histological regression is also there, those patients ideally would be the candidate for surgery. And what surgery is, you will have to do an total abdominal hysterectomy with bilateral salpingo-oophorectomy. But if the patient is younger, you can preserve the ovaries, but definitely salpingectomy is something which needs to be done. Endometrial ablation by all guidelines says that they are not that recommended and they should not be done in the recent guidelines which are there. So management of endometrial hyperplasia with atypia, the gold standard management here becomes the surgery. But what happens, there are some women who really want to, they get early changes and they really want to have fertility. And we are worried about the progression to cancer because we know it is not always 100%, but it is 30%. So with close counseling, what we can give them is the first line treatment being the LNG IUS and the second line being oral progesterone as a best alternative. And these are the RCOG guidelines which have said that we really need to assess this patient A proper fertility consultant needs to discuss the options of conception. And again, the assisted reproduction techniques may be considered, because we cannot wait for them to go for natural conception and later on have any problem, because we really need to monitor the endometrium also. So these require a very, very good approach. And these patients, if they are really obese, then they need to reduce their weight, and their BMI also should be less than 30 before they plan conception, because high BMI is one of, again, a predisposer factor for endometrial hyperplasia. What about the surveillance that you do every 3 months till 2 consecutive negative biopsies are obtained? So every 3 monthly, you will put them on surveillance, and disease regression should be achieved for at least 1 negative endometrial sample before the woman attempts to conceive. So we really need to first cure the condition, stabilize the endometrial report, and then plan the pregnancy. And what will be the initial, how the atypical hyperplasia would be? See, this all is the guidelines from the RCOG, and they also have said that there is, you can either do the hysterectomy, either a laparoscopic use, that is a grade B evidence, but there is no need for frozen section or anything. So this treatment can be given at any center, and not necessarily a frozen section is required. But endometrial ablation is not recommended, as we discussed earlier. So these are the guidelines. What about the patients who want to conceive? This is already done. And coming to the HRT and endometrial hyperplasia, some patients who are actually on HRT and then they come with endometrial hyperplasia. So you should really remember that when patients who are taking systemic estrogens, and you really need to avoid, if patients are not having a uterus, you cannot give estrogen. And if you're giving an estrogen, you really need to give a progesterone along with it, so that there is a withdrawal bleeding, and that needs to be taken care. Putting an LNG IUS or supplementing a progesterone would be very adequate for the patients who are having a uterus, so that hyperplasia is not there. So this is very important in terms of HRT and prevention of endometrial hyperplasia later on. And now coming to this is a flow chart of how you go ahead with an endometrial hyperplasia management, that is with without ATP and ATP. This is all what we discussed, the LNG IUS being the first line, and fertility considerations need to be taken. The endometrial hyperplasia needs to be evaluated every 6 months, but atypical hyperplasia every 3 months. And then you need to put in first line the LNG IUS, continue for 5 years, again reassess the patients, correct all the high risk factors, and if there is no responsive to treatment, then only advise them hysterectomy. So it cannot be straight up a hysterectomy, but you will have to go in a sequential manner. A good follow-up, a good counseling is something which is required, and we can, this algorithm sum up the entire thing what we actually discussed. What about the future science? Because we know that the things are going to come, so that they have been discussing so many things about the biomarker, the clinical factors, also the effect of weight loss, community-based obesity surveys, the lifestyle programs, even the bariatric surgery which we can offer. Is there any role in regression of endometrial hyperplasia? These are the future research. Also the optimum duration of oral and local progesterone, how to maintain and induce the disease regression. Then there are evaluation of endometrial surveillance regimes. So we need to follow, or they may come up in future. Prospective long-term follow-up, women observed or treated for endometrial hyperplasia. So we really need to know what is the factors which predictive of disease persistence, progression, and relapse, and role of LNG IUS in HRT associated endometrial hyperplasia. So you have already given an HRT. What is the role of LNG IUS in this? So this may be a recommendation for future research. And with that note, I think I have completed the entire topic. And I thank you all for your patient hearing. And thank you so much, all of you. Thank you. And sorry for the problems with the slide. I think they were just jumping and not moving properly.
Excellent talk as usual, Komal. You have covered everything. It is the thin endometrium which is troubling us during ART, but simultaneously thick endometrium at the perimenopause, menopausal age is really difficult, and it needs a strict surveillance. We need to take proper history because There may be many risk factors in the family as well. So we have to look into, we have to do proper sonography, transvaginal sonography, Doppler flow indices, and we have to investigate thoroughly and to take decision. And if patient is willing for fertility, then to strict surveillance is needed. You have done great job, Komal. You covered everything.
Thank you. Thank you so much.
Yes, dear Dr. Komal, very, such a big topic, and I was wondering how are you going to do this in 20 minutes, but it is amazing that you went through each and every aspect, right from the basic history, etiology, and algorithms of management, and not to jump to hysterectomy. So really, tremendous job done. Thank you. Thank you so much.
Thank you. Thank you so much.
I thank the chairpersons and the speakers for this session. And I now request Ekika to introduce the chairpersons for the second session. Dr. Ekika. Dr. Ekika, are you there?
I think there must be network. Pradnya, you go ahead.
Connection issue. So I would like to invite the chairpersons for the second session, Dr. Namrata Bhardwaj. She is a consultant at Bhardwaj Nursing Home and Laparoscopic Center, ex-assistant professor at JN Medical College, Aligarh. She's won several awards and has given the Kamini Rao Oration, chaired several sessions and has various publications. She has been a part of Foxy Adolescent Committee and has been the organizing secretary of UPCOG. Her special field of interest is in high-risk pregnancy. And she is the founder secretary of Aligarh chapter of ISOPAP. The second chairperson is Dr. Suman Sinha. Ma'am is a senior consultant at AHIVF and Infertility Center, Ranchi. Director of Advanced Care and Maternity Center, ex-chief of Medical Services and HOD at CCL Hospital, Ranchi, which is a subsidiary of Coal India. She's been the president of Ranchi Obstetrics and Gynecological Society, is an coordinator for Medical Disorder and Pregnancy Committee, and organizing chairperson at Foxy East Zone conferences. She's been the convener of Public Awareness Committee, Foxy, has been the secretary of Ranchi OBGY Society, vice president AOGSBG, and vice president of Solsi Bihar and Jharkhand chapter. She has been the president and secretary of ISOPAP and has been invited as faculty for several conferences and has had several publications. I request the chairpersons to introduce our second speaker, Dr. Kundan Ingale. Can you please flash Dr. Kundan Ingale's introductory slide?
Thank you, Dr. Ekika. Thank you, Komal ma'am. Am I audible?
Yes, Dr.
Yes, okay, ma'am. I have the pleasure of introducing Dr. Kundan Ingale, sir. He has been the chairperson Infertility Committee and the current session from 2022-2023. Director, Enigmatic Endometrium Center for Assisted Reproduction and Endoscopy. Director of Moses Basket ART Bank, Pune. General Secretary, POGS. Founder Treasurer, Maharashtra chapter of ISAR. My God, the list is so long, Dr. Ingale. I think we can go on and on. He's been awarded the best research paper in ISAR 2019, second best research paper at ISAR, and presented the first time research at the 6th COGI Bird Congress in Vietnam. We have the pleasure of having Dr. Ingale with us. Can we have your talk, sir? We can't wait to hear you. You're muted, sir. Kindly unmute yourself, sir.
All right. So good evening, everybody. Thank you, chairpersons, for those kind words of introduction at the outset. Thank you, Dr. Komal Chavan, such a good friend and close friend. And so many months, I think I wanted to come to this your webinar series to just share my views, and you have given me chance in this particular episode. Thank you so much for that. Today, I'm going to discuss about evaluation and management of thin endometrium. And, this is one of the very important area which I feel all the research is actually going into this direction only, because rest of the things, it's something like we have already achieved it. I hope my voice is clear and my slides are clear. Okay. So, friends.
Yes,
Yes, sir.
Yes. So there is no clear-cut definition of thin endometrium, but for all research purposes, all the papers, what they are following about a definition, and that is endometrial thickness if it is less than 7 millimeter on longitudinal view on transvaginal sonography. Either it has to be on the day of ovulation or anytime after ovulation. If that kind of thickness you see, you can call this group of patients as a group having thin endometrium, but there is no officially accepted definition. Now, it's very important that this definition has been made to follow certain research purposes. That doesn't mean that there is a 0% pregnancy rate below 7 millimeter. That's very important. But this 7 millimeter cutoff is coming from the evidence because they saw that there is a significant drop in the clinical pregnancy rate, especially if the endometrium goes below 7 millimeter in comparison with a group having endometrial thickness more than 7 millimeter. So that is very, very important. Now, exactly what happens when you call it as thin endometrium, because thin endometrium is something ultrasonic feature of your endometrium, and actually what is happening at molecular level, that is very important. So it is characterized for important changes. One is a high blood flow impedance of radial artery. So there is a decrease in the endometrial blood flow because of the increased resistance into the spiral arterioles. Second, because of the inadequate growth or because of the some kind of previous damage, there is a poor endothelial growth, endometrial growth, that we can call it as an epithelial growth. If you look at the molecular level, there is a decreased VEGF expression. We know that VEGF is very essential for the angiogenesis, and also there is a poor vascular development. So we have to keep these things in mind. Now, if you look at, this was the very good concept launched in 2018. One of the European Spanish colleague, that he something he labeled as endometrial niche area. That is what is you can see on the left side of the diagram, where you see these endometrial glands, and this area where all the spiral arterioles are present and the glands are present. So you have two types of stem cells. One is mesenchymal like stem cells, and second one is a progenitor stem cells. So, there are two types of stem cells. One stem cell which helps to for the expression of endometrium cells, and second stem cells which are actually causing angiogenesis. So if the endometrial niche area is, kind of interfered by some kind of injury or some kind of pathology, which is leading to deposition of fibrous tissue, that all leads to thin endometrium. Now, simply understand, if you need an optimal endometrial growth, what we need a good level of estrogen, which comes from the follicular development. You need a delivery of this estrogen to the target tissue, which comes from a good blood flow, because it is produced from the fat and the ovary. It has to come to the endometrial area or uterine, which is through a good blood flow. And of course, the end organ is very important. So utilization of this estrogen to make the glands response. So that is mediated through peripheral or endometrial natural killer cell activity. And there were these are the three important pillars. Now, obviously, on these three important basic pathophysiological pillars, you have three mechanisms because of which thin endometrium happens. So if you have a low estrogen level, you will get a thin endometrium. If you have a reduced endometrial blood flow, you will get a thin endometrium. And if you have an endometrial damage due to surgery or infection, which leads to fibrous tissue deposition in endometrial niche area, you will get a thin endometrium. Now, there is what do you mean by endometrium receptivity and thin endometrium? Are they same or they are different? See, endometrium receptivity is the only ability of endometrium to facilitate successful embryonic implantation. And this implantation needs a receptive endometrium, a blastocyst stage embryo, and a complex sequence of signaling events which are happening between the embryo and the maternal tissue. Now, receptivity is something which is mediated by many markers. So there are biochemical markers, there are cytokines, there are luminal markers, which are actually, they are part of the endometrium receptivity. To call it as a receptive, we need these markers to be present. And if you want to assess the endometrium receptivity, then we take a use of structural markers, that is histological diagnosis or histological picture, and ultrasonographic markers like thickness, that's pattern, endometrial blood flow, and endometrial wave direction. Now, this is what is very clearly mentioned. These two things are different. Even if endometrium thickness is less than 6 millimeter, you have almost 43% patients having still receptive endometrium. And that is why we do see that successful pregnancies are still happening, even if somebody has less than 6 millimeter endometrium. Though only the percentage of these patients are going to be significantly low. Okay, so that we should not call it as a cutoff. Okay, so that's very important. We have to understand that endometrium receptivity can still be present even if you have a thin endometrium. Now, many times it has been said that even if you have a more endometrial, there is a problem in the implantation. But look at the receptivity is present even if endometrial thickness is more than 12 millimeter, it is almost 65%. So I still put it in this way, that even if you have an endometrial thickness up to 16-17 millimeter, still you will have a much better clinical pregnancy rate. Not only that, you will have a good ongoing pregnancy rate. So do not abandon the cycles if somebody has got an endometrial thickness beyond 13 millimeter or 14 millimeter. Now, how can we diagnose? It's most by this definition, it is by ultrasound. So it has to be done either on the day of ovulation or on the day when the follicle is 18 millimeter or 19 millimeter, or anytime after ovulation. And if a patient is unovulatory, then you give a estrogen from second day up to 16th day, and then 16th day you can check the endometrial thickness. It has to be longitudinal view, and you have to measure the maximum thickness in whichever area is available. Sometimes you do have a thin endometrium at the fundic region, but you may have a mid cavity having a better thickness. You measure that mid cavity thickness, and that is to be interpreted. You have to look at the triple line pattern as you see into this third picture, and also assess the endometrial blood flow by color Doppler, and also check the pulsatility index and resistance index in arterial signals, especially in zone 3, which is a subendometrial zone. And your PI value has to be below 1, and RI has to be below 0.6. And the peak systolic velocity has to be more than 10 centimeter per second to call it as a good subendometrial blood flow. Now, a simple and a very good study regarding this point has been done in 2014. Very clearly, they demarcated that if somebody has a good subendometrial blood flow, their pregnancy rate, their clinical pregnancy rate, and implantation rate are almost double and significantly higher in comparison with a patient who's got a very poor endometrial blood flow. It is almost double. So we follow this protocol in every patient, that even if in frozen embryo transfer cycle, in hormone replacement cycle, we don't start progesterone till we achieve these parameters. That is peak systolic velocity more than 10 centimeter and PI has to be below 1. So you keep on giving estrogen for a little longer time, or you can increase the doses, but achieve these parameters, your chances of ongoing pregnancy rates are going to be high. Applebaum score, I think Dr. Applebaum has given a fantastic score. Of course, it is little tedious to do it in a everyday practice, but yes, if you look at it, includes endometrial thickness, it includes layering, that is triple line pattern, endometrial motion, that is waveform pattern, then myometrial echogenicity, then uterine artery Doppler flow, endometrial blood flow, which I mentioned, and myometrial blood flow on grayscale examination, everything 7 parameters. And it has been documented that, if you have a good score, it is associated with definitely a better kind of pregnancy rate. So this was a study by Applebaum score in 2016. And if the score is almost 20 or above that, it is 97% pregnancy rate. If the score is 17 to 19, it is almost 85%. But if the score goes below 16, the pregnancy rate drops down to 28%. So if you want to be little accurate, follow this score. It will always help you to assess the prognosis. There are other ways of also assessing endometrial blood flow, and for that you need a special machine which has to have this kind of software which measures the vascularization index, the flow index, and vascularization flow index. So again, they have proven that if the vascularization index is significantly higher, you have a better pregnancy chances. So next level of investigation in this direction is the endometrium volume assessment. It is a structural marker to be used to in cases of thin endometrium. So what you do in this, you take the help of 3D transvaginal scan and check the uterine cavity volume, and it has been documented that if a patient has a volume less than 2 centimeters square, 2 millimeters square, it is associated with a very poor reproductive outcome, very higher miscarriage rate. And if it is endometrial volume is less than 1 millimeter square, it is associated with a very thin endometrium and associated with a absolutely zero implantation rate. So if you follow these cutoffs, if you can ask me what is the normal volume, it has to be 5 centimeters square. Coming to the management, once you have diagnosed the thin endometrium, these are the strategies. You can take the help of estradiol, hysteroscopy, aspirin, vasodilator drugs, endometrial injury, GCSF, platelet-rich plasma infusion, and stem cell therapy. Let's understand which one is best and which one we have to just leave it behind. Let's understand about estradiol and its effect. Now, this was a fantastic study in 2013, after which I think in my practice, my results changed significantly, and that was giving estradiol for a little prolonged time. Now, this patient, this particular study is actually showing us about estradiol supplementation starting on the SCGD for the patients of thin endometrium. It actually does not provide any benefit on the pregnancy outcome. So when you see any patient who is undergoing IUI or IVF, and if you have a thin endometrium, you always feel like, I should give a estrogen supplementation. Don't give it. Stop. Do not give estrogen in a luteal phase. It doesn't help to improve endometrium. But this is the study which I'm talking about, that 2006 study, which has been very nicely demonstrated that they selected 36 women with thin endometrium, which was below 8 millimeter. Almost 23 fresh embryo transfers were 23 patients undergone fresh transfer. The pregnancy rate documented was only 4.3%. But remaining 13 patients, their embryo transfer was cancelled. Now, in the next cycle, what author did, they give a extended estradiol supplementation. For a few patients, they gave it right from 14 to almost maximum 82 days. That is extended estrogen, means in for a more days. And they found that the endometrial thickness, which was mean in this 13 patient, was 6.7. It rise to 8.6 millimeter, which was beyond our average endometrial thickness. And they documented pregnancy rate. Even with the same patients, they would have undergone fresh embryo transfer. They would have received only 4% pregnancy rate. They received with almost 38.5%, which is almost close to 50% of your good endometrial patients. So extended estrogen administration is something very, very beneficial, and I recommend. We did our own study, though it is unpublished till now. We did only presented at IFFS conference, and we documented that if you give it for minimum for 30 days estrogen for such kind of patient, the endometrial thickness is increased from 8.6 to average mean to 10.47, and we'll come back to. So almost the mean rise in endometrial thickness with extended estradiol was by 1.84 millimeter, which was significantly better. Yes, hysteroscopy is one of the very important thing, and we have to understand that the surrounding endometrium may appear normal in case of intrauterine adhesions, but the vascularity is compromised in the presence of intrauterine adhesions, and women with an atrophic endometrium typically complains of amenorrhea or oligomenorrhea. So those who are having extensive intrauterine adhesions, they are associated with the lower pregnancy rate. You have to put in a hysteroscope. You take care of these, all the adhesions, and you will see that there is an improvement. So what you exactly doing is, let's go back to that second slide where we see fibrotic tissue deposition into the endometrial niche area. You are basically excising fibrotic tissue and allowing those stem cells to proliferate and do a better endometrial growth and better vascularity. What about aspirin? This is a clinical trial in 2000 where aspirin, a group who received aspirin compared with a group who did not receive aspirin, and they found that with aspirin, only significant change was in a trilaminar endometrium pattern and the pregnancy rate, which was 18.4%. But they did not find any difference in the thickness or kind of PN and RI values of uterine artery and spiral artery and ovarian dominant follicle. So aspirin therapy could not significantly increase the thickness. It increased it proven to be giving us a better picture, ultrasonic picture, that is triple line pattern, better pregnancy rate, which was significantly higher, but it did not increase the endometrial thickness. So you have to understand where aspirin we have to use it and where we don't want to use it. So third part is the vasodilator drugs and effect on endometrium. Now, when it comes to vasodilator, first thing comes in our mind is a vaginal sildenafil. And in this randomized placebo control trial in 2020, they selected this group of patients very, very clearly, age less than 38 groups with a normal reserve, 2 prior failed IVF attempts, and endometrium was less than 7 millimeter in those prior cycles. Now, 22 patients out of this group received sildenafil. Another 22 patients received placebo for 7 days, then followed by sildenafil for 4 days, and group 3 received only placebo. And they found that there was no significant difference in endometrial growth or even the outcomes of pregnancy between all 3 groups, whether you give sildenafil or whether you don't give. So that was a, again, you have to understand it was a randomized placebo controlled trial. Again, a very, very well done study. Though sometimes we do find that giving sildenafil in few patients, we find it, yeah, it has made a lot of good change, but evidence is against it. Pentoxifylline with tocopherol, I think one of the very good drug. Pentoxifylline, and it is a phosphodiesterase inhibitor and derived from methylxanthine, which causes a vasodilatation of arterioles. Tocopherol acts as an antioxidant. So there are few studies which has been, they have studied this combination where pentoxifylline was given 800 milligram per day and vitamin E was given 1000 IU per day. But important, this therapy needs 6 months administration, and that's a drawback of this, that you have to wait for your patients for 6 months to complete this therapy. And they have documented that endometrial thickness significantly increased from 4.9 to 6.2 mean, and they reported pregnancy rate with 33%. Even another study which again showed that it definitely improved the endometrial thickness. Almost 40% they got pregnancy through natural or ovulation induction and frozen embryo transfer. So again, one of the good drug strategy, but again, it just needs a lot of time. What about endometrial injury? Yes, I think some kind of principle where the injury induced the inflammatory response, and that leads to elevated levels of certain pro-inflammatory cytokines, which are very important marker for successful implantation. That was a proposed therapy. But meta-analysis in 2019 showed that whatever studies we did, 10 studies almost, but endometrial injury should be used restrictively and not routinely in the clinic. And still we have a very insufficient evidence to support the use of endometrial injury in women with the implantation failure, specifically because of the thin endometrium. So this endometrial injury is something which is obsolete now. We don't practice anymore. But can we do endometrial scratching in women undergoing first embryo transfer? So again, current evidence does not support that we should not do any endometrial injury with the purpose of improving the success of first embryo transfer attempt. Next molecule is GCSF perfusion and effect on endometrium. We know that GCSF important mechanism is that it mobilizes these stem cells, which we understood in the initial slides, from bone marrow into the subendometrial niche area. For that, you need a GCSF. Not only that, GCSF activates neutrophils, and they release VEGF, which is actually important mediator for neoangiogenesis. And that's why we see a better improvement into the endometrial blood flow. There are good papers in like this one in 2014. They did documented with the use of GCSF, clinical pregnancy rate was 18.9%. who did not conceive with because of the thin endometrium, and they documented that it definitely improves the endometrial thickness after at least minimum 72 hours by minimum rise by around 1.68 millimeter. So very important study and good molecule, which I'll recommend. And this meta-analysis also in 2018 says that it is definitely beneficial to improve clinical pregnancy rate in IVF and ET patients. But they definitely said that the route should be subcutaneous injection rather than transuterine. And it works very effectively. And with subcutaneous only recommended, or probably what I have tested into my own studies, 100 microgram per day is the sufficient enough to mobilize your stem cells to see a better endometrial blood flow. Few points about platelet-rich plasma. I think it's a very widely practiced nowadays. It contains a lot of platelet-derived growth factors, AB and BB, and transforming growth factors. And it has been shown that it promotes the endometrial growth and it also improves pregnancy outcome. But you have to understand, very important, that it reduces our cancellation rate of the cycles, and also it gives a higher pregnancy rate. But as this study in 2019 said that after the first PRP infusion, you hardly see an endometrial rise. You have to repeat it after 48 hours. And after second infusion, 48 hours later, when you evaluate, you will see that there is a definitely increase in the endometrial thickness by almost 2.3 millimeter mean size. So PRP is something which is effective. Now, there are a lot of studies which are coming that we are using PRP in a subendometrial region. Again, good findings which we are getting from observational studies, but we did not have a constructive evidence. So it is still under experimental, I will say, but there are promising results with subendometrial injection of PRP. Last word about stem cell therapy for thin endometrium, because again, it is a novel treatment method from regenerative medicine. So sources of stromal and hematopoietic cells, which comes from either menstrual blood-derived stromal cells or umbilical cord-derived mesenchymal stem cells, or bone marrow-derived mononuclear cells, or peripheral blood-derived mobilized population. So these 4 different sources are there from which you can utilize this. And trials does says that they are showing a promising findings, but with demonstrable safety and early proof of efficacy, temporary amelioration of intrauterine environment, and increase in endometrial thickness. But please remember, stem cell therapy is still considered as a only experimental therapy. You have to counsel the patient and you have to make them understand that this is only experimental. Don't tell them that this is a therapeutic. It's very important. We don't know tomorrow in medical legal era, where we can be taken to the court for the treatment which is under experiment. So friends, just to summarize, precise and specific endometrial maturational development is very, very crucial for successful implantation. Ultrasonic thickness, endometrial pattern, and volume computation and blood flow analysis are the methods by which we can assess them. Microscope is very, very important. And strategies like prolonged estradiol administration, vasodilator drugs, then use of GCSF, PRP infusion are the only evidence-based solution which you can utilize to improve endometrial growth. But estradiol during luteal phase or aspirin or endometrial injury are just not helpful to improve. So don't practice that. And in persistent unresponsive thin endometrium, one can advise patient to undergo surrogacy or adoption. Do not hesitate, because that is something an ultimate option instead of giving them repeated failure. So nothing in life is to be feared. It is only to be understood. Now is the time to understand more so that we may fear less. That's a fantastic saying by Marie Curie. And thank you for the patient hearing. Thank you, Komal, for giving me a chance to share my views about thin endometrium. Thank you very much.
Thank you, Dr. Kundan, for such a nice walkthrough for the thin endometrium. It was very nice because I think you covered all the aspects, right from the surgical and the medical management. There are 2 things which I would like to ask you, Kundan. I mean, in that study where we give extended estradiol from 14 to 82 days, what is the dose? I mean, and in your study, you said you increase the dose 2 milligram every 72 hours. So what is the maximum dose which you used?
Okay, in 2006 study, they did not increase it, gave a fixed dose for a longer time. So that was the 2006 studies. In our studies, what we did, we took a kind of a hypothesis from our mechanism of endometrial hyperplasia. In fact, Komal discussed that if you have a higher estrogen levels, so probably you may have an endometrial hyperplasia. So what we did is that we kept on increasing estrogen doses every after 72 hours by 2 milligram. So when you start with 4 milligram, after 72 hours, you go to 6 milligram. Then after 72 hours, you go to 8 milligram. Like that, we kept on increasing till we find a desired level. Now, the study which I presented, that was a prospective study. So we decided in that study that we will not cross 30 days. Okay. So at the end of 30 days, the dose which patient received was 24 milligram per day at the end of 30 days. We checked the estrogen levels for all these patients, and none of the patients' estrogen levels were beyond 600 nanogram per ml. So, it was never beyond 600. So the fear which we had in our mind that maybe estrogen may lead to, thromboembolism.
Yes, that's what I wanted to ask. My reason was this for asking.
Estrogen circulatory level beyond that, even 600, which can cause thromboembolism. And we did not have a single patient
Okay.
had thromboembolism.
So that is my reason for asking that question was.
Thank
And
you,
secondly,
Dr.
what about just one more thing? Because I think he is doing a lot of work in this. So just one more thing I wanted to ask Kundan. Kundan, what about endogenous estrogen? I mean, what about the use of letrozole or mobiclomiphene cycles for embryo transfer in these cases where we don't have a good endometrium? Like these will increase the endogenous estrogen. So do you find any good results with that, or whatever is that exogenous supplement which you said?
Yeah, I did not find it because the simple thing is that estrogen is an aromatase inhibitor. So what it's going to do is it's going to inhibit conversion of estrogen from testosterone. What it ultimately do is in fact the anti-estrogenic effect. Okay, so I did not find any kind of this kind of effects, to improve the endometrial thickness. Okay, just because we want to increase the estrogen. Okay, so I did not find this kind of result. Yeah.
No, probably what they say ki once there is a follicular growth with letrozole or clomiphene, so the endogenous estrogen which is secreted from this follicle will act better on the endometrium for the growth than giving an exogenous estrogen supplementation. So probably in some cases of thin endo,
I understood. You're actually talking about comparison of ovulation induction cycles.
Yes, precisely.
Yes,
giving to these patients who are having thin endo for embryo transfer.
In fact, when during frozen embryo transfer, we see thin endometrium, and this patient, once we do a letrozole induced cycle, we see a better endometrium.
Yes, that's
but
what I was
understand one more thing, that there are 3 studies which has been done to compare these ovulation induction cycles with frozen embryo transfer with HRT, but they did not find the increase in the pregnancy rate. They are still the same. So probably you may feel that the endometrial picture is better with letrozole, but ultimately your ongoing pregnancy rate and clinical pregnancy rate did not change. So in fact, what they recommend, they say that, a modified natural cycle is one of the method which is equally better, but only problem is that it has associated with a higher cancellation rate. Okay? So letrozole is one of the good drug, but again, I follow HRT because simply there are 2 advantages. First advantage is that you can control the cycle. You can have a full control when I want to start progesterone, when I want to schedule my
that's true.
You have a full control. Second advantage is that suppose you are dealing with a patient who has a borderline endometrial growth. I think here you have an advantage that HRT cycle you can prolong giving estrogen, and if it is under down regulation, it's fantastic because you can administer estrogen as long as you want, maybe for minimum 20 to 30 days, as shown by my study, and you still have a almost increased by 1.64 millimeter than what she will develop anyway. So I think that advantage, and that's why these 2 advantages I follow this. But all the studies done and comparing these 3 different protocols, they say that none of the protocol is superior than each other. They are still the same, and it's a completely user's choice.
User's choice to do what. Okay. Thank you. Thank you, Kundan. Please go ahead, Dr. Sabai.
Yeah. Thank you, Dr. Kundan Ingale. It was really a very fantastic presentation, so crisp and so extensive. I'm also working in infertility center where I see that in the IVF patients where we have been started the patient on all the drugs for the IVF, we continue the estrogen throughout the cycle till patient doesn't, even after patient has conceived, we continue with the Proginova for 2-3 weeks, and then we stop. And we are getting good results, and the pregnancy outcome is also good. So here, what we are practicing, that is, it is only with the estrogen in our small cities, but we don't have any experience with the GCSF and the other PRPs and all. So I just wanted to know that since you are working in a bigger place, so are you practicing only with the estrogen or with the PRP and GCSF and all?
Again, if it is an ovulation induced cycle or probably your fresh embryo transfer, then in that case your estrogen supplementation in a luteal phase doesn't help. And even it is
talking about this thing frozen. If it
frozen embryo transfer.
And it has been studied that if you stop the estrogen once the beta HCG is positive or urine pregnancy test is positive, so both the groups has been compared, that one group did not receive estrogen ahead of positive test, and one group received estrogen for 7 weeks. they did not find any change in the pregnancy rate. So once the pregnancy test is positive, there is no role of giving estrogen. It will not increase or decrease your chances of continuation of pregnancy. So
Yes.
Absolutely, evidence is very clear.
Because I've been practicing this for a long time, so I really wanted to confirm, can I stop it or not stop it? Okay.
Yeah, you should stop. Once it is test is positive, you stop it.
Thank you.
Dr. Kundan, may I take, sir, may I take this opportunity to congratulate you, sir? Sir, Dr. Kundan, sir, may I take this opportunity to congratulate you, sir, on your extensive knowledge, your extensive experience, and your knowledge of literature, not just your practical experience, sir. It was amazing. The way you talked about your subject, and also the way you answered our questions, sir. Thank you so very much. It was a pleasure to listen to you, sir. Thank you,
Doctor. Thank you.
So with this, we conclude the second session. I would like to thank the speaker, Dr. Kundan Ingale, and both the chairpersons for chairing this session. Now we'll begin with the panel discussion. Our moderator for this panel is Dr. Ganpat Sawant. He is the ex-HOD, Department of OBGY, D.Y. Patil Medical College, Navi Mumbai. He is a director of Noble and Noble Plus Hospital, Ghatkopar, Mumbai. Ex-president, Ghatkopar Medical Association, Mumbai. Past honorary secretary, IMA branch, Mumbai. And he is a managing committee member of MOGS. And he has passed from the prestigious AGS Medical College. Our expert for today's session is Dr. Niranjan Chavan. Sir is the professor and unit chief at Lokmanya Tilak Municipal Medical College, Sion Hospital. He is a joint treasurer of FOXY, current president of Mumbai Obstetrics and Gynecological Society. He is a member of Oncology Committee CEFOC, joint secretary AFG, dean of AGOG and chief content director of Hygrad and FEMAS courses, editor-in-chief FEMAS and JGOG. I request Dr. Ekika to introduce the panelists for today's panel discussion on endometriosis. Dr. Ekika?
Okay. Yeah, can you hear me? Oh.
No. So, Dr. Ekika, can you unmute yourself?
Yeah, I have, but can you hear me? I mean, there is some disturbance in connection.
Yes, we can hear you.
Hello? Yeah, okay. I'd like to call upon Dr. Dinesh Kansal. He is President DGES, Delhi Gynecology Endoscopy Society, Convener and Examiner for ICOG Fellowship Program, Director Head at BL Kanpur Hospital, Delhi, Robotic Surgeon trained at Harvard University, Boston, Graduate and Postgraduate from Grant Medical College, Bombay. He has organized and operated in many national and international workshops, including AAGL, FOXY, SAPOG. Satyapal, he has received a lot of awards: Satyapal Award, Times of India Excellence Award, Abdul Kalam Award, ICOG Award, and Best Video and Hysteroscopy Award. He is successfully running laparoscopic surgery fellowship program at BLK and published many articles and books in journals. Sir, welcome you for the panel as a panelist. Dr. Anuradha Khar, she is director at Nurture Specialty Women's Clinic and Fertility Center, MD Obs and Gynae, Government Medical College, Srinagar. Fellowship in Reproductive Medicine from Bangalore. She has done her medical from King George Medical College, and she was assistant professor at KMC Bangalore. Infertility and IVF specialist, consultant, obs and gynecology, executive committee Karnataka chapter member, and has a lot of publication in Indian Journal for Surgery. I welcome Dr. Anuradha Khar as a panelist. Dr. Vidya Bhatt, she is medical director at Radhakrishna Hospital, Bangalore, and she is course director for training courses in advanced FOXY and ICOG recognized endoscopic training and FOXY IVF training at Radhakrishna Multi-Specialty Hospital. She has also conducted a lot of hysteroscopy hand-on trainings. She is being invited in many collegial conferences as an honorary faculty for state and national conferences, presented more than 300 papers and posters, and awarded as a Best Paper Award for ovarian healing. I welcome you, Dr. Vidya Bhatt, for the panel. Dr. Amit Ashok, Medical Director at Archit Hospital, Executive Member of Foxy International Academy, Exchange Committee, Joint Secretary, Nasi Ops and Gynae Society, faculty of many conferences and workshops as a speaker and operating faculty, Consultant Gynae Endoscopic Surgeon, ex-consultant Gynae Endoscopic Surgeon, Cloudland Hospital. His special interests are advanced endoscopy, assisted reproductive techniques. I welcome you, Dr. Amit, as a panelist. I think Dr. Pradnya, can we start now?
Yeah, we have a few more panelists. Dr. Subhash Mallya, he is currently operating and will be joining us shortly. He is the chairperson-elect, Foxy Endoscopy Committee and Secretary of Calicut Society. The other panelists, can you just run through the slides? Dr. Tanvir, consultant at Tanvir Hospital, Hyderabad, Telangana, member of the Program Subcommittee of Education Committee of IUGA, Executive Committee member of UPI. The next panelist, Dr. Smeet Patel. Yeah, she joined. Dr. Smeet Patel is director at Mayflower Women's Hospital. His MBBS from NHL Municipal Medical College. He's operating and he'll be joining us shortly in another 5-10 minutes. And another other panelist is Dr. Anu Chawla. She's a specialist in reproductive medicine, editor, International Journal of Human Reproduction and Development, and is the editor of International Journal of Fertility, Bangladesh, North Zonal Foxy Coordinator, and additional Joint Secretary, ISAR, New Delhi. I welcome all the panelists and I request the moderator, Dr. Ganpat Sawant, to start the panel discussion.
Okay, thank you very much, Pradnya, for that exhaustive job of calling all the panelists and moderators. Friends, it's so nice that along with the introduction, you have put the photos, otherwise it becomes so difficult. In Maharashtra, Dinesh is actually male and Tanvir, we do not know what is it. So it's a mixture of all
female,
the people.
Sir. It's a female, sir, not a male.
I know.
Tanvir is a female.
I'm just jokingly saying, making a mood little lighter.
Okay, yes, sir.
Yeah, because what
No,
I
I'm
was
just
saying
kidding.
is it is a good that it is put everything there. And if you see the panelist, it's a covering from Srinagar to the other part, that's a Kerala. So we have a mixture of people from all over the country. And that's very, very, very nice. And that we are going to have a practical approach towards the today's discussion. That's the endometriosis. So can I have a screen of mine? So this is what my panel. Can you see it, the slides?
Yes, sir, we can see your slides.
Okay, so this is what we are.
So could you just start the slideshow? Yes.
Yeah. So this is what basically we are lucky to have Dr. Niranjan as an expert today, because he is so busy and he's our dear president of Endometriosis Society. Then Dinesh madam, you are there, but I'm so happy to know that you are from JJ Hospital. Anuradha madam, I was lucky to be with her in Turkey and enjoying the trip. Vidya madam, and that so many people I was with them for different occasions. Amit is a bright boy who is working in interior of Maharashtra and is doing wonderful work in the medical college in Loni. And Subhash, so everyone knows, Tanvir madam, good you joined. We read the message that you were traveling from Bangladesh to somewhere else. And Smeet and Anu madam, we had a chance to meet her in different activities in Mumbai itself. I like this quotation which is put by this Rakesh Jhunjhunwala. And it was published a couple of years back saying that nobody can predict certain things in life. Like something like weather. If the meteorological department says it's going to rain, sometimes it becomes a bright sunny. And then sometimes death, we do not know what is going to happen to us tomorrow. Market, that's a fortune, what is going to happen. Similarly, I can't say woman, but I can say endometriosis is unpredictable. We do not know which cases are going to be symptomatic, which cases are going to be asymptomatic. And today's topic is so nice that it started with endometrium, enigmatic endometrium. In fact, I say, look, when the endometrium is thin, it's a problem. When endometrium is little hyperplasic, it's a problem. And when endometrium is lying outside its position, it still causes a bigger problem. And that's what the basically endometriosis which is going to have. Now, I will not go into the theory part of it, but this is just to put it here, theoretically how it started. So my first question to, and this is the multiple sites where the body can go. So my first question to all of you, over a period of years, whether you have seen any new etiological factors for endometriosis, that's one. Two, whether it's any specific age it is been seen more commonly, and ethnicity or high risk factors. What we try to do is, let's be practical. We will not discuss theory in the sense according to Cochrane and all those things, but may I start with Dinesh madam and go one by one, please? Yes. If Dinesh madam is not there, then we can go to the Anuradha madam.
Yes. Hello.
Yes,
Hello.
yes, we can hear you.
Yeah.
Please
So
go ahead.
age. Yeah. Should I start answering? Okay.
Please go ahead, madam.
Yeah. So age, we know that endometriosis. What is endometriosis? Basically, endometrium, that is uterine endometrium, coming out into the peritoneal cavity. And we know that since menarche, when menarche happens, so periods start coming. So after that only endometriosis will start. So now what I'm seeing in age, of course, it's a disease of reproductive age group. We know that. And now what I'm seeing a shift is more and more adolescents I'm seeing. Adolescent girls coming with dysmenorrhea, or, while passing stools, they get pain. This age shift little bit I'm seeing from the reproductive proper to the adolescent group.
Very nicely put it. Initially, we used to think it is going to be there, though it is a peak, it occurs in the reproductive age group, but it is not uncommon in adolescent age group. And I think nowadays we have become so much clinically oriented, and clinical acumen has also increased so much. In young girls also sometimes we do see a severe endometrium. So we have a panel which is covering from one end of the country to other end. I mean, can others also comment on this point? Yes, in our part, this, say, for example, I personally think in South states, the endometriosis is here more severe type, it's more common, and even if it's seen at the extreme of, that is at the perimenopausal age, also it has been seen. So can somebody from that zone or your opinion can add to it? Subhash, Tanvir madam. Yes, Niranjan.
Sir, I want to add something that since few months we are doing operations in Guwahati, in northeast area. We have seen a lot of cases there and severe endometriosis there in that particular region in northeast.
Okay.
Yeah, I would like to add here that it's not only confined to reproductive age or young women who are just married or adolescent, but I find also endometriosis in women who are having 2 or more children. So it's at the age of 30, 35, when they already have children, 2 or 3, and then they have endometriosis. So this is something very different that I have found.
True. So it is there that none of the women is sort of resistant to develop. And this, while reading, in fact, I have come to know about one more point is some of the factors which are actually causing less endometriosis are protective. And I was so happy to read that increased BMI and waist to hip ratio sometimes helps in reducing the incidence of endometriosis. So it's so important actually that not necessarily all the time obesity is bad or the high BMI is bad. There's something good for them also. And as all of you said, it's a syndrome and it can be seen any age of the, any age. So let's go to the, now from this, let's go to the first case, which is very, very simple. And I put it here so that we get, in general, the view of all the panelists. And typically this patient is 29-year-old infertile patient, which she had an increasing dysmenorrhea. And on sonography, the report comes as 4 centimeter left ovarian endometrioma. So it's a typical straightforward case. So it's open for discussion to all the panelists. Again, I would like to hear it from Tanvir madam that yes, what is the choice of treatment and how you will go ahead with the treatment. Very simple. Yeah.
Hello, sir. Good evening. Please just call me Tanvir, sir. And before I answer that, I have Professor Rane here who wanted to say hi to everybody. So
Okay.
I'm just going to say hello. Yeah.
You are in dark.
Hello,
Can you
Niranjan. How are you?
Niranjan, unmute. Niranjan, unmute.
Sorry. Hello.
Well, thank you. Who is this?
Hello.
Dr. Rane.
Professor Rane. Ajay Rane.
Oh my God,
This is Ajay
Dr. Rane. I could recognize
How are
you.
you, sir?
I am so happy to see you.
Yes, we are
It's a
very,
great
very happy.
pleasure. I'm sorry to barge in. We're
I
doing some
recognize-
humanitarian work in Bangladesh.
I recognized your voice. Ani tu kasa ahe?
Oh, Pune man.
Hey,
Pune
ekdam
man.
majet
Yes.
hai.
Oh, that's so nice. Now you are
Ekdam
given,
majet.
you are given this an
Well,
international.
let me hand over to Tanvir.
Yes, yes. Thank you.
Okay.
Thank you,
Thank
sir.
you.
Thank you, sir, for joining. Thank you.
Thank you.
Thank you, and all the best for your meeting. I think it's a great job you're doing.
Thank you.
Yeah.
Hello, sir. Thank you, Niranjan, sir, for inviting me, Komal ma'am, for inviting me. So, Ganpat, sir, the
Yeah.
answer to this, what is the choice of treatment, medical or surgical? I would do, if she's an infertile lady, I would do an infertility workup first, do her AMH, and just check her AMH, discuss with the patient both the options of medical and surgical, whether she wants to give a trial for pregnancy, because I think 4 centimeter endometrioma would be slightly borderline. She has dysmenorrhea. So I will give her an option of surgical first, but also give her an option of medical if she wants to go ahead, and then proceed discussing with her what she would want to go. But I would, and for how long. Medical would be at least for 3 months is what I would give her a choice, and then go ahead with surgical if she agrees to it, because she's symptomatic.
So Tanvir, it's very, though I said a straightforward case, she has visited 4 doctors before she coming to us, taken a treatment for infertility, and now says, Dr. Tanvir, you are the best judgment for us, and you decide now what is the best for me. So basically, she has been told.
So she's already.
Yes, she's already told about the different modalities.
Yeah.
She's
She's
saying
already,
now.
if she's.
Yeah, go ahead.
Yes, sir. She's already taken treatment for infertility and
Yes.
it's not been successful. Then I would definitely advise her that it's best to go ahead with an excision of the endometrium, because it's only one-sided. I would also give her an option of maybe going for embryo freezing before that, if depending on the AMH, sir, because you've not put it up. So I'm not sure how much is the
AMH,
I'm not sure how much is the AMH.
I have not put it because we want to discuss about it. That is, yes, we should do AMH, and sometimes after surgery it might go down or it might be less from the beginning. So as a counseling part, we wanted to have everybody's opinion that yes, we should have an AMH to be done before doing the surgery. Only thing I wanted an opinion of everyone, whether somebody wants to give a hormonal treatment before going ahead with the surgery or with the surgery. That is what point of discussion is.
Sir, I have one point to make. It's about the workup of the woman. Yes, we will do an AMH. It's very important, not only for the decision, but also to see whether we really should go in for a surgery. Second thing is the male partner has to be evaluated. Depends like on the semen analysis. If it's a severe oligoasteroteratospermia, then the treatment may change and our further treatment. So it helps in counseling also. So the male partner as well as the female partner, we have to work up as we work up any infertile couple.
So that is, though it is not put, it is being done. Only thing, how many of you are there for the direct surgery? How many of you want to give a medical line of treatment that is something like OC pills, GnRH analogs, or Dinazol, or your choice? Is any one of you interested in giving or directly for surgery? Because I just want to know the opinion of everyone so that otherwise we go ahead with the surgery.
Sir, as you said that the patient has already undergone certain treatments outside and the patient has increasing dysmenorrhea. This is the main important line. So we can offer surgery. I would like to do a surgery because of her increasing dysmenorrhea if AMH is fine. And also she is taken treatment outside. So taking everything into consideration, though it is just a 4 centimeter endometrium, there's no harm. Plus, we will also know about the tubal status. We can check the patency of the tubes. We'll get much more information if we do a laparoscopy on this patient.
Very good. So her AMH, as I know, it's around 1.3. And this is how the situation is. 1.3 is the AMH. So what precaution you will do? Whether you want to operate, and if while operating, what precaution you would like to take it. Otherwise, also, I think even if AMH is around 3, we'll take the same precautions, though we will tell patient about its disadvantages. Yes, Anuradha madam. Any difference if AMH is less and AMH is more? Unmute. Okay, so Anu madam, you
now
want to take
AMH, if it is low, now you have put me in a fix. It's 1.3 is quite low. AMH depends what your reference range is. But then I would still reconsider, because see now here, because AMH is low, and you know, I don't know whether they've done IUIs earlier. If they've already done and it has failed, then I would like, I'll do an ultrasound definitely. I will see how the accessibility of the ovaries is. Now that becomes important here. If there is a 4 centimeter endometrioma with adhesions and the ovary is not accessible, then in that situation, I'll go for a laparoscopy here. In this particular
if ovary is accessible from ovum pickup point of view, or ovarian aspiration for the endometrioma?
No, I am not. We should not do aspiration for these cases. I would only for the egg pickup thing. Egg pickup thing, I would look for the accessibility of the ovary.
So you don't,
because the AMH is low now, right? We may think of going for an IVF for this patient. So
Anu madam, yes. Anu madam, any opinion from your side? I hope you have heard the case.
Yes, I've been hearing everything. So hello to everybody, and hello to you, Dr. Ganpat Sawant, and to everybody else in the panel, Dr. Niranjan, Dr. Komal, the whole gang. So first of all, I think you have presented this case and the chief complaint is the increasing dysmenorrhea, but then you added another history that she has taken fertility treatment, but in the question you've not mentioned fertility is her concern. So I want to first of all clarify, is fertility her concern? And is it is it an ongoing concern for her right now at the age of 29? Yeah, okay. So according to according to the guidelines, the only 2 indications of surgery are, the first is increasing dysmenorrhea. The second is the first indication of surgery is increasing dysmenorrhea despite medical treatment. The second is accessibility. So if the ovaries are not, the follicles which are to be drained in the egg collection are not accessible because of the endometrioma, these are the only 2 scenarios where we operate generally. So if it is increasing dysmenorrhea, I would want to explore what all medical therapies has she already taken, or can we just counsel her for more? Because I have to be very careful about when do I give the first surgery to anybody, because the second surgery is always bad and endometriosis can come back, and she might need a second surgery at the age of still just 35. So I would want to defer surgery as much as possible and keep her conservatively managed, because I also am concerned that the 4 centimeter is not a very big, but at the same time, the grading doesn't really depend on the size in case of endometriosis. It's a pelvic disorder. So I won't get too carried away by the size also sometimes. AMH has no relevance when we decide surgery. I would just do AMH if she wants to. So obviously I can do antral follicle count and tell her about the ovarian reserve. If she also wants to know more and do another complementary test, I can do AMH, but AMH will not help me decide surgery or not decide the surgery by all means. Definitely at any level of AMH, I will be very conservative when I operate this patient. very delicately. And surgery definitely will be deferred as much as possible, is my opinion. I would not go for the surgery without exploring if all options of medical management are still not explored for her. For example, Dynogest is something we can actually, people have been using it for over 4 years, and it's a long time that we can use Dynogest for. So I'm rather a conservative doctor.
So it's so much of opinion difference, and that's what we basically want. And this is what very selectively I have chosen, though it looks very simple. First of all, this patient is an infertile patient. She's very, very keen to become a pregnant. Second thing is, she is a symptomatic, that is a premenstrual pain and a dysmenorrhea. 4 centimeters, if it would have been 8 centimeters, job would have been little easier. And that's why it has been put as a 4 centimeters. So it's all things put together. And now she's so desperate that if you try to do this Dynogest or GnRH analogs or whatever method you are practicing, it is going to still delay chances of her pregnancy, though symptomatically she will become better. So this is how the difference of opinion and everybody's opinion is going to help us. What was done to this patient was basically, she was basically taken for the laparoscopic surgery. So what next thing I just want to know is, in laparoscopic surgery, what all things you would like to do and how you will see that all the points which you have discussed for a preservation of ovary follicles, what different methods you will use and how will you conserve maximum ovarian tissue. Any one of you can take it.
Yeah, now that you've done the surgery, definitely, Dr. Dinesh, I'm handing over to you. I'm just going to say that, yes, if surgery is decided, then as a pre-surgery measure, I will then do AMH to see whether the surgery has decreased the ovarian reserve, but not that it is going to decide for the surgery part.
No, that point is very clear. Yeah. Yes, Dinesh madam, nice to see you. Hello.
Yeah, hello, good evening, everyone.
Good evening.
Yeah.
Good evening.
Can you hear me?
Yeah, very well.
Dr. Dinesh, so pleased to see you actually.
Thank you so much.
We can hear.
So here, the first step we do is observe the extent of endometriosis, bring ovaries to a normal position, and if required, we do a retroperitoneal dissection. But in a case of mild to moderate, we don't have to go retroperitoneal. And once the ovary is brought to normal position, there are 2 methods. Some people like to go at the punctum and then do the dissection, but I feel if you make a cut at the normal position, like, where the punctum is not there, at the place of normal ovarian tissue, with scissors, no energy source, you can nicely get a plane between the cyst and the ovarian tissue. And then gradually by traction and counter traction, you can do away with the cyst. So this is one thing. And the second is any other endometriosis that you see in the pelvis, I think it should be removed. Whether they are these chocolate burn lesions, usually there's a lot of fibrosis below. So it's tip of the iceberg. So we should excise that. And secondly, very often we get mild endometriosis at the insertion of uterosacrals, and that also be excised because we have the opportunity. If we leave it, patient will come with much advanced years later and may go up to the rectum also. So at least I personally have started excising this at the base of the uterosacrals also.
So may I add?
Yeah, Tanvir, go ahead.
Yeah, sir. So 2 points I just wanted to add is you can inject vasopressin routinely. So it's easier to excise the cyst wall without using any current, and there's no bleeding. Especially near the hilum, it's really stuck. So you got to be very careful near the hilum because you don't want to pull it out too much. So you can inject your vasopressin and get it out. And second is, if the ovarian cyst is large, you can also suture the ovary and not use electrocautery, and that is a hemostasis. So if anything else you want to add, sir.
Yeah, regarding the hilum, if we are not able to get a good play near hilum, rather than using cautery and doing too much dissection, we may just leave a little bit of endometriotic tissue with the ovary because we don't want to hamper the blood supply. And there's another thing that you just spoke about very large cyst. This patient has a small cyst. If the cysts are very large, like 10 centimeter or more than that, nowadays what we've started doing, and that is the norm now, that you aspirate the cyst at that time and do adhesiolysis and put the patient on a single dose of leuprolide. And after 1.5 months, when the cyst has shrunk in size, then you do cystectomy, because then you can save maximum ovarian tissue.
Very interesting and little debatable point which you have raised. You said somewhere you put a small part of endometriotic patch at the bottom where you cannot remove, or it's going to bleed little more. So is it not going to cause recurrence if you put, because some people say we should remove it totally more and the bleeding will stop, or with the stitches the bleeding will definitely be stopped, or different techniques, though we may not use excessive electrocautery, but leaving behind some part of endometriosis. I mean, I do not know how many
We don't like to leave it, but if there's no good plane, normally we get a plane, and if there's no good plane, and that is where the ovarian supply is coming, so if you happen to damage that supply, use bipolar or any method of electrosurgery, it may not be good. So either it comes out with blunt dissection easily, or I think, in the same patient, it may be different cyst on both the sides. But if you think it's too much stuck, then it is best to leave a little bit, because the recurrence has to happen.
It's very interesting because the cyst wall in endometriosis will come out easily, but not always. And as compared to the other cysts, this is definitely a little more reluctant to come out easily. So then we land up, and that's why this discussion is there, whether it's electrocautery, whether it's hemostatic agents, and something has to be used. And see, there's so many methods have been used here. So which one all of you are using here? Does anybody using laser? Is somebody using, I think somebody did mention about the vasopressin, which is quite commonly used. And I just want if any one of you are using laser or sclerotherapy for these endometriomas. If not, then we move ahead, because laser practically unless some corporate hospital or somebody who is practicing abroad, whether they have used it. But otherwise, if not, then we can. Anybody has any opinion about this or experience?
One thing, vasopressin can be used in the broad ligament, or it can be used in the, in the ovarian tissue to separate the cyst. So that is one thing. And second is CO2 laser we have used, but the literature also shows no difference in the results, whether you use cystectomy without any laser or with, say, laser. So it is not found to be much useful. So no need of doing any fancy things, though we have in our corporate hospital. The urology department has it, but we are not using it routinely because we didn't find any advantage. The only thing is very large cyst where you are not able to peel it off. Either use a superficial bipolar coagulation, or what we can use is CO2 laser, because it's got a fixed thickness, how much it's going to penetrate. But I think it doesn't have much advantage.
Okay, I think little bit we move ahead, and I don't know how much time organizers are going to give us, but there's a little kahani mein twist hai karke I have put this. Now the same situation, only thing here the patient is a young, little bit 25-year-old, but she's single, she's unmarried, and accidentally it's diagnosed as 4 centimeter ovarian endometrioma, and it's a patient is asymptomatic. So this is the patient in front of you. She's worried about, because she has read so much about it. So I just want again everybody's opinion. Asymptomatic single patient, 4 centimeter ovarian endometrioma. Would you like to touch it? Yes or no? Or you want to give definitely a medical line of treatment so as to prevent a further progress? I mean, what Amit is there? He is gone. I do not know. But yes, anyone can take it again.
Yes, sir, I'm here.
Yeah, Amit.
My question
I'm
is,
asking you because you are a surgeon. Your hands are always
sir.
itching. You feel like nahi dikhta hai to nikalna hai. That's why.
But sir, in this case, I'm not going to dikhta hai to nikalna hai. because
Okay.
she is symptomatic and it's accidental finding. My question is, how can we come to diagnose that that is endometrioma? In first scan, how can we label it as endometrioma?
How can we label? Now, I don't think it's so difficult to diagnose endometrioma on sonography. And
So can I?
yeah, go ahead.
Can I answer?
But nowadays,
So,
we, here where I am practicing, here we found a lot of times the radiologist give report as a endometrioma, and after 3 months there is no cyst.
So that is not a problem with the endometrioma. It's a problem with the radiologist. That's okay. That's okay. Yeah, I think Tanvir was
True,
speaking.
sir. Yes, sir. So I would I would do a simple determinants of in ultrasound and either ask my radiologist to do it or do it myself. And if I have a doubt, then do some ovarian markers. And PA125 is going to be normal and it's going to be high, and the rest of it would be normal if it's an endometrioma. Usually, iota is not required, but you're good enough with simple determinants, you would know it's endometrioma. And then I would just, I guess, follow up after 3 months because she's asymptomatic, depending on what she wants.
Every 3
Can I
months,
answer?
it
Can
up
I
with
answer?
sonography. Yeah.
Can I
yeah.
answer?
Yeah,
I
yeah.
think, as you said, that a good sonologist will always diagnose an endometrioma, except in the early stages when the blood is very thin. It has not become a proper, that thick, tarry substance. That tarry substance, when you have, you can easily diagnose. The initial part look like a hemorrhagic cyst. So what I do is I give them 2 months of oral contraceptive pills. And most of the time, if it's a hemorrhagic corpus luteum or a simple hemorrhage, they will settle down. They will settle down. We call them again for an ultrasound, and I've seen a lot of patients like that. So I would like to go for a medical management in this case and give an OCP cycle, maybe couple of cycles or 3 cycles. That's how I would go about it, not do a surgery.
Okay, thank you. Anu, yeah.
So I totally agree with Amit here, actually. I will not make an imaging-based diagnosis of endometriosis, although the new updated ASHRAE guidelines says that imaging has more role and laparoscopy should obviously not be used for diagnosis only. So, but at the same time, using imaging as the modality to diagnose has actually created a void in this topic of gynec. When we say how to diagnose endometriosis, actually we don't know how to do diagnosis apart from surgery, and we don't want to do surgery to do the diagnosis only. So I will very carefully see the family history, any significant family history of cancers in the patient. I will explore all other things. I will do the markers. And rightly, Dr. Anuradha mentioned in the initial bits, it's actually not an imaging diagnosis at all. We can say there's a cyst which looks like endometrioma. We can never be sure it is endometrioma. How are you ever going to stamp that it is not something worse? So I will do at the end of the day.
Just to cut the long story short,
the annual follow-up is also important.
It will go somewhere else. To tell you very frankly, from expert person and a gynecologist doing this sonography, diagnosis by sonography is not that difficult. First. Second, of course, we cannot do a
but we
scopy
can't
for
100%
diagnosis.
stamp it.
There is nothing like 100% in medicine, but
Yeah, so
yes,
annual follow-up I'll do to see that, and
it.
once a year scan. Yeah.
No problem. We'll do whatever. That's what I wanted. What question is in this case, whether this patient which is presented in front of you, how often you scan, do you treat in the first shot? And like Dr. Anuradha said, I will give OC pills for a couple of months. And I mean, see, there is so much of this topic. It's so, what I'll say, difference of opinion. So that's what we want to know, because diagnosis is be done. We are not discussing how to diagnose the endometriosis.
Okay. So no treatment. I will not give her anything. Yeah.
You will not give her anything. So progressively it will increase, and we'll wait for the signs and symptoms of, developing signs and symptoms.
It might just stay like that forever.
Forever, okay.
It might stay the same 4 centimeter for 10 years. For 10 years, I can't put her on OC pills.
No. She did not say put for 10 years. She said a couple of months. So could it be 3 months, 6 months?
But if I start OC pills, when do I stop then? What is the limit?
So that's the
I don't
question.
start.
So that's the question. That's what the full discussion is about. I mean, you
Yeah, I
just
will
want
not
to wait
start.
and watch as it is. Do you want to give medical line of treatment to only symptomatic patients? Do you want to give medical line of treatment to control the progress of the disease? I mean, what you want to do it? I just want, again, everybody's opinion. Yes.
OC pills are not known to control endometriosis anyway.
Okay, that fair enough, because now newer OC pills containing estrogen, progesterone, dinogest, and all those things will definitely help them to control somewhat. So with this, I think anybody want to add more controversies to this? No, then I'll go to the next case, which will take a little bit more time. And then we will stop. This case is something different. Before I go ahead with this case, have you seen any rare, this, what I took first is a simpler case, then it was the asymptomatic in a single patient, and then we had a difference of opinion, which is bound to be there. Now, third case is little uncommon presentation of endometriosis or adenoma. So can you, any one of you, label rare cases or rare presentation of endometrioma or adenoma which you have seen? Starting from Anuradha madam. Rare presentation, not the typical pelvic or uterosacrals, umbilical, lungs, diaphragm, inguinal canal, labia, something like that.
Vaginal
had-
endometrioma.
Yeah.
Sorry, ma'am. Go ahead. Yeah.
No, you go ahead.
Yeah, I've come across vaginal polyps or lesions presenting as endometrioma.
Okay.
Histopathology came out to be endometriosis. So there were about 10 polyps in the vagina, and she had come with intermenstrual bleeding, especially post her sexual contact.
Okay, well, something interesting, nice. Yes, I think that vaginoscopy is going to be more helpful in this kind of patients too. Yes, Dinesh madam.
Yeah, we had a case of catamenial pneumothorax. The patient would develop pneumothorax repeatedly during periods. So ultimately, our respiratory department did, fuse the pleural membranes. But she still has endometriotic lesions, so she's on medical treatment and she's doing good till now. If she does not do well, she's completed her family, maybe I'll remove her ovaries. So we are just waiting for further how she behaves. Yeah.
Okay, anyone else? So I'll go ahead with this, my case. This is a 45-year-old patient. She presented with severe dysmenorrhea and menorrhagia. Hello? For which she was operated for laparoscopic total hysterectomy with left salpingo-oophorectomy and right salpingectomy. Patient was that time 42-year-old and she wanted to conserve one of the ovaries, at least if they are normal, and that's why we had conserved. This is the picture which is seen here, intra of findings. This is the pouch of Douglas. Look at the picture, how it is there, and this is the right ovary, looked normal, that's why it has been conserved. And this right ovary was fixed to the round ligament. It was fixed to the round ligament so that we thought it will be nicely hitched up there. And this is the picture which is seen after fixing the ovary. What had happened is, after 2 years, patient comes back to us saying that she has a pain in the right iliac fossa with the backache and right leg pain. After sonography, it showed oval lesion of 43 by 22 millimeters seen in the right iliac fossa near the deep inguinal ring. And that time immediately what I did is I put in a needle, took out the fluid, sent it for cytology. Cytology said it is suggestive of endometriosis. And believe me, after this FNAC, patient's symptoms had gone down. It has become less. Again, patient presented after a few months saying that, doctor, this pain has again increased. And then we got it MRI done, which showed again 46 by 28 by 29 mm lesion along the right inguinal canal. So what do you think this diagnosis is? Anyone can guesses? And this MRI kept on saying it could be lymph node, it could be neoplastic lesion, or it could be hernia, and things kept on moving. So before
what was the contents of the aspirate?
It was the little bit darkish fluid, which cytology showed it is an endometriosis.
Okay.
I put in the report also here. Cytology suggestive of endometriosis, right anterior abdominal wall, cyst FNE, that is the fluid which was there. After that, the patient came back again after a few months with this MRI report showing there is a lesion which is increased and is symptomatically very, very bad. So what we did is, in this case, repeat laparoscopy, let's see what is it. This is the ovary which was fixed. This is the round ligament. And we kept on tracing the lump. And this lump which was there, you can see it very well. It's in the extra pelvic part of the inguinal canal. And that we dissected. And on dissection, this part, which is the whole lump, which we removed and send it for the biopsy or the cytology. And that cytology report, yeah, somebody speaking?
Very nicely managed.
But it took a long time, and this is really some of the rare things. Look at, this is the ovary, then this is the round ligament part, and this is the lump which we have removed. Of course, there was a surgeon there standing by, and this one was showed as endometriosis of the right ovary, adenoma of the right round ligament, that's the lump which was removed. And then this is how the case was presented. So this is what I just thought I'll bring it to the everyone's notice. For me, at least, this was the first time I had seen it. And then though the first picture I had put it, look at this round ligament, is the one of the rarest sites, but still it can be there, it can be found. And this is what those sonography and the MRI kept on saying. It could be neoplastic lesion, it could be lymph node, it could be hernia. But yes, all these possibilities, we do have to keep it in mind. So this is just
sir,
to have
sir, it was, since it was involving the inguinal ring, did you put in a mesh or something to prevent inguinal?
No, we did not put in a mesh. And I did mention the surgeon who was standing there, he was washed up. He said the defect is a small, there is no need of mesh. With Gore-Tex suture, we sutured it, and patient now till date is fine. And why I put it here is, and that's why I ask you how some anecdotal cases or rare cases, if you have seen, we can put it. So this is one of the rarest findings of these things which we can, see it. So I just want to put question to all the panelists. What is the etiological factor for developing right inguinal adenoma? Whether hitching the ovary is the culprit, whether it was there in the beginning which has become symptomatic or more, just to have a wild thought or discussion. Personally, I think the right ovary which was fixed to the round ligament, and there must be some element of endometriosis in that ovary itself, whether it's migrated. So this is just for your opinions. Yes, senior person starts first. So Dinesh madam immediately unmuted.
Yeah, but it's so rare, difficult to give opinion because we don't have our own experience in this. Very well managed.
I know. Amit?
Sir, I feel that hitching the ovary is the culprit because it is a case of endometriosis, and the TLH base is the only option.
So can we say henceforth the patients with the pelvic endometriosis or ovarian endometriosis, ovary should not be fixed or hitched? Just to make
Sir, what was the age of this patient? Sorry.
When we operated for the first time, it was 42 years of age. And then second surgery, what we did, that time she was 45. So this is how it was there. If there is no opinion, then I think now it's already 7 o'clock. In the next 5 minutes, I think we will stop, and I will just put 4 questions.
So,
Yeah.
Yes, sir. So, yes,
Yeah,
sir. I think, sir, for this lady, if she's already we were operating for adenomyosis, then bilateral salping oophorectomy along with hysterectomy, and go ahead with hormone therapy is what I would do, even if she's 42, she's young, because we know endometriosis comes back. So we give a low dose hormone therapy.
Good.
To
I think
these
Tanvir
women.
had a cup of tea in between. So she's already
No, I did not, sir. My network was bad in between. I was just logging off.
But I think the more important part is the oophorectomy.
Yeah, that's already, Niranjan sir has already pointed
And
out.
I think oophorectomy is not something that should be taken very lightly.
Very good. That's a very nice message.
Because you can get residual ovary syndrome, you can get ingrowth of the ovarian stroma into the retroperitoneal space, and it can definitely inadvertently affect structures close to the psoas muscle, including the iliohypogastric nerves. So oophorectomy is something that should not be done routinely.
True. That's what we wanted to discuss and have opinion of everyone. This was fixed to be done.
I think Dr. Tanvir brought out a very good point. If a patient has adenomyosis and we are operating, we should counsel her. If we find any pelvic endometriosis also, I would like to do BSO. So patient should be counseled.
I think castration of a woman before the age of 45 should be also taken very seriously, because although we are very desperate to treat endometriosis and remove everything possible in that woman, she also needs quality of life afterwards. So I think one has to be very careful about BSO just because it's endometriosis. It has to be stage 4, possibly with pretty severe symptoms. Then only one should consider a BSO. I think the effects on aging, in fact, in women who have been castrated is extreme, even if you give her HRT.
So I totally reckon with what Dr. Rane has said, because till the age of 90 years, ovaries have positive impact on cardiac and bone health. So it is a very big thing. It is a very big thing to decide to remove somebody's ovaries, please.
So, and with the more longevity, in fact, still is going to be problematic, and that's why we take a proper consent for the ovaries, and with the proper consent, this ovary was preserved. Unfortunately, she had a different problem. That is the sad part of it. But otherwise, before surgery only, I think our decision should be there. Intra-op, I really do not know whether we should take a decision.
We should also emphasize what is proper consent. When we do a improper, very biased and coerced consent, कि तुम्हारे ovaries में endometriosis है, so it will save you a second surgery, so let me remove. So then obviously she's going to say yes, remove. So in the consent, we have to properly give her the information, that is also very important. Because if we tell her, okay, we are doing this to save you from second surgery, she's going to say yes. This is not a consent.
And plus how patient's education level, how much she understands, and so many other factors will be there. Yes, now we come to this is just, we can say this is sort of rapid fire kind of things, and next 5 minutes we might close down. So this is the case post-cesarean section. She comes with the pain in the right side of the scar. So this is what we have operated. So what is this diagnosis?
Scar endometriosis.
Scar endometriosis.
Simple, scar endometriosis, but at the same time you can see something here which is the non-absorbable thread which is seen here. So I just want to know, can that thread itself be a culprit to cause the endometriosis of the scar?
No, because all the cases we have seen is there has never been a scar. There's never been a thread. So
thread.
Yeah, so we have not seen it. So this will be something new if you say that was the culprit.
No, I'm not. See, I have also seen for the first time. So basically, see, we have to think from all angles. because all patients, they do not develop scar endometriosis.
Yeah.
Of course, some of them they develop, but now using such kind of threads, and the patient was typical, very smart girl. She would keep on saying, yes, before the menses, at this point, I get something. And clinically, we will not be able to palpate. This was this CT scan which was diagnosed. At the time of surgery, we also had a difficulty in tracing it. But yes, we could get it and we have removed it. And this is the part after removal. And it is, yes, it is this scar endometriosis, which is histopath also has said. We have gone.
But sir, she had a cesarean, so there will be threads there. Non-absorb, I mean, delayed absorbable. Some thread will remain for one year.
But we are not using nowadays non-absorbable sutures. At least at our places, we don't use it.
Maybe some people use, maybe they've
Possible. Somebody must have used for that patient, no? So that's why I said, yes, whether that is the, this is a lab picture of the patient. And then this is the picture, which is through the cystoscopy.
Bladder endometriosis.
So I think we'll stop it at this point of time, and I just want closing remarks from all of you. Endometriosis, of course, it's an enigmatic disease, and it's going to have different presentations at different ages also. So just few closing remarks, and we will stop again at this point of time. So starting from any one of you can start. Okay, Dinesh madam, again, let's go from senior to junior. No problems.
Yeah, the last case we would have liked to discuss, and it was so interesting, but of course we are falling short of time. And I think you covered everything, right from early endometrioma, small endometrioma, asymptomatic. I think that was the best we could have discussed. Thank you for that.
Yes, can somebody throw a light on this RNA? There are so many things we are reading, and there are so many messages coming about the diagnosis in recent advances about this microRNA. Does anyone have some kind of more experience with this? I don't have any.
I don't have any experience, but I know Philippe Decombe is doing it in France from the salivary kit, and anybody who wants to be a part of it, he is welcoming everybody to be a part of the study. So if you want his...
What is it? You just tell us, what is it? I mean, how do we I mean, from the salivary...
I think I'm not the right person. I know a little bit of it. So I think
okay.
So but what I know is that he's the main guy, Philippe Decombe, who's doing this research in France, in Clermont-Ferrand, and his, he's the boss of Endometriosis Institute in Anglara, something.
Sir.
So basically he's inviting everybody to be a part of his study. So if somebody wants to get in touch with me, I can share his contact details.
Dr. Sawant, I have one point to make, that recent ESHRE guidelines, whatever we have, they are not recommending any biomarkers in endometriosis as of now. They have said that till further studies come, they have said that, biomarkers are not needed for the diagnosis. Their main focus is diagnosing endometriosis based on ultrasound and MRI. And they have also said that don't use laparoscopy for diagnosis unless the patient is very symptomatic. These are the recent ESHRE guidelines which I wanted to cover. And for symptomatic endometriosis, OCPs are the first line of treatment, not GnRH agonists as earlier we were using.
Absolutely. I want to add one more point. In the new guidelines, they have also mentioned one more point with far more emphasis than ever before, which is creating the EFI graph of the graph after the surgery and handing it over to the patient after you do the surgery. So EFI, which is very much emphasized in the new guidelines, should be promoted at the time of surgery. Although we all are not doing it, I know, but that is
we are not doing. But when you are doing, when the patient wants fertility, wants a baby, they say that EFI should be done for all post-surgical cases, and depending on the EFI, they decide that if it's less than 5, then you can take from 12 to 24 months to do the treatments for fertility and not rush them for IVF. But if the EFI is more than 5, you can directly send them for IVF or ART treatments. That is my concluding remark.
Very nice. So you're a strong follower of sonography and believing in our own investigations, which, yes, and I feel dunia goal hai, going from again biomarkers to so many advances. Again, we come back to our original clinical judgment, and yes, let it be any what do you say, that artificial intelligence or anything come, which is not going to replace the human brain. As we are going to become more and more senior, we are going to pick up it in more ways. And but one thing we have to be very, very agree to the fact that endometriotic surgeries are not routine surgeries, and they have to be done by the experts. It really requires extensive and a careful dissection, and it requires a complete treatment as far as possible during that surgery itself. I had put in a few questions there actually to repeat surgeries and so many things. There are so many patients who come back after first surgery. And about the ovary also, after doing hysterectomy, after doing 1 hour removal of tubes, patients, they do come back with the ovarian lesion, and they're more difficult to remove. So it's a very balancing act about managing the endometriosis, whether it's surgical or medical. So thank you very much for that wonderful inputs. And I like your strong belief in whatever you people do it, because there has to be difference of opinion. Otherwise, if everybody says yes to one thing, then there is no fun in discussion about this.
Ganpat, can I just say something
please.
for a second? So we have a very simplistic way of consent with the patients. It is divided into 6 words. She speaks, I speak, she speaks again, we decide. That's how we look after every single patient in our clinic. I'll repeat, she speaks, I speak, she speaks again, we decide. That decision may be that we do not agree with each other. That decision may be that you should go and see someone else. But it is a decision that is made jointly because the patient has been given 2 opportunities to speak. Finally, most patients will come to you and say, what will you do, doctor? What do you do then? Then
that's what I had said. Yeah, go ahead.
Then we do what is called the mother test. The mother test is very simple. What would you do to your mother? What would you do to your daughter? You will never, ever be wrong. Mother-in-law, different issue. But mother, if you do the mother test, so it's very simple. She speaks, I speak, she speaks again, we decide. And if she says, what will you do? I tell her on her face, I am going to now do the mother test. And the mother test is telling me that you should have this. This is what I would do to my mother. There cannot be a better way to convince a patient that you're genuine about what you are thinking as far as your compassion for the patient is concerned. I'm very, very sorry to have butted into your clinic. We are doing some humanitarian work in Bangladesh, but it's lovely to see you all. That's why when she said Niranjan is there and Ganpat's there, I could not stop. I had to come and say hello and say hi.
No, that's
Tanvir?
our pleasure, and we really love the way you speak and convince others. But you have made one point clear, always she speaks first.
100%. 100%. There is no way out of this. There is
what
no
I
way
meant
out
to say
of this.
is, whether in the clinic or at home or anywhere else, she speaks first. And that is a better way to maintain the harmony.
And last. She speaks first and last and instead of.
Yes. So Niranjan, bye and thank you. Niranjan, your final words.
What can I say? Like this guy, this guy is like a special guest appearance, like how Salman Khan comes in Shah Rukh Khan movies, or Shah Rukh Khan comes in Salman. And Niranjan's movie, Komal's movie, I can see Ajay Rane from Bangladesh. I'll go mad. I'm going crazy now. And really, Tanvir, this was the highlight
Thanks
of
to me,
what you
sir.
have done. This was the surprise
I
moment.
was like, sir
can't-
is there, you have to come and say hi. I
Oh
told him
my God.
you have
This
to
is
come and
such
say
a-
hi to Niranjan.
Yes, thank you, Tanvir. And that's what the long lost friends we have been knowing for each other for decades, and the affection and the care what we have for each other goes for decades. And Ajay, I want
Yes,
to
yes,
meet
sir.
your Ajay, I want to meet your naughty
One
nephew
second.
who had come in AAGL. I hope I will see him again in 2022. I would like to see your naughty nephew from Australia.
Well, we'll see how it goes. At the moment, we are seeing a lot of gender-based genital violence, which is what the work I'm doing currently in Rohingya camp in Bangladesh. It's a serious issue, but we're doing okay. So yes, we'll see how we go. So thank you so much. Tanvir, why did you give me the phone? Thank you. Goodbye.
Thank you very much. And Komal, thank you for making us a part of this
Ganpat, I'm not
wonderful
finished
task.
yet.
Yes.
Sorry?
I'm not finished yet.
No, of course not finished. Your last word has to be there. Yes.
So
Go ahead.
You can go ahead with the vote of thanks, but before that, I'm just
Niranjan, go ahead.
I'm very happy. It was an excellent panel discussion, very well discussed, and such a important practical points have come out of the panel discussion. That is very important. All the esteemed panelists have contributed immensely. So I'm really happy. Thank you so much. And now Dr. Niranjan Chavan can take over and conclude it.
Well, as
And
said,
thank you, Dr. Rane. I am really happy and surprised, and I really loved it.
Thank you, Komal. That's no problem.
Thank you, Ajay. So nice of you. You made our day today, and really thanks to Tanvir once again. I'm going to give you all a treat once we meet all of you, and really
Done, sir, for sure. I'm going to remember that.
Yes, and I'm going to meet all of you. Well, Anu, what can I say about you? You're the most wonderful person we have met, and the ties with London is going for a long ways. And you're doing a wonderful job of coordinating along with Dr. Rishikesh Pai as the president, Madhuri Patel as the secretary general. So much work is happening, and especially last 3 months, it's really going good. And I'm sure we look forward to see you in Mumbai and in India soon. Thank you. Thank you so much for joining with us, Dr. Anuradha
Thank you to
Khar.
you and to Dr. Komal.
Dr. Anuradha,
Thank you, sir.
for joining. Your points were very well taken and accepted by all of us. I think experience makes.
Thank you. Thank you.
She is now in IAG, and we are very proud of her. She is heading the Delhi Gynae Endoscopic Association. Thank you so much for being there. Dr. Suman Sinha, Dr. Shivani Gaur.
We can't hear anything.
Dr. Niranjan, your voice has
We can't
gone.
hear Dr. Niranjan.
Really.
Amit Tajane, thank you very much.
Screen is frozen.
Thank you, Dr. Komal and Dr. Niranjan, and
The topic
thank
is
you, Dr.
endometriosis,
Sawant,
that's
for
why
this
it's frozen.
wonderful panel. I thank all the panelists. It was a wonderful discussion, and we look forward to more.
Yes, I would like to thank the moderator, Dr. Ganpat Sawant, sir, for conducting an excellent panel discussion. And the difference in opinions and management really, made all of us think about the correct management. And we enjoyed that the panelists disagreed on so many issues that made it more interesting. And with this, I would like to thank Dr. Komal Chavan, madam, and Dr. Niranjan Chavan, sir, for inviting all of us and giving us the opportunity to be a part of this wonderful program.
Yeah, thank you. My connection went away, but I would like to thank again Amit. You are so kind of, to be joining us from Nasik, Sangamner, and others who have joined, Shivani, Ganpat Sawant. Thank you for those wonderful lectures. And of course, the case is very rare and very different cases, especially the round ligament. And thank you, Ekika, from joining. What a wonderful job you have done during. He has told that there was a crowd of 350 to 400 members when he had just visited Mau, when the Yatra was going, Vadlav Yatra. And really, we look forward to see you soon in the few meetings further ahead. So thank you with all these things. Of course, Komal is there with me, and really we look forward to all of you joining in the future. So have a great day. Thank you. Take care. Bye.
Hi, bye.